This lecture will be about a topic that you probably never cared about, ICD-10 codes. Let's start off by defining what are ICD-10 codes. ICD-10, the International Classification of Diseases, 10th revision, is a standardized system used to code for diseases and medical conditions. What's the difference between CPT codes and ICD-10 codes? While both of them are medical coding systems, CPT codes identify the specific medical procedures or services performed on a patient, or what was done to the patient, while ICD-10 codes represent the patient's diagnosis or medical condition, or why the procedure or service was done. Essentially, CPT codes are for procedures and services, and ICD-10 codes are for diagnoses. To properly document your work, you should list all ICD-10 codes for all diagnoses found and treated during an emergency department visit. The ICD-10 official guidelines for coding state that the diagnosis is based on, quote, the highest degree of clinical certainty for that encounter or visit, such as symptoms, signs, abnormal test results, or other reason for the visit. You do not need a final diagnosis, but use the ICD-10 code which best describes your clinical impression, whether it's a diagnosis or sign or symptom, and be as specific as possible. Do not use the terms probable, likely, suspected, or rule out. For example, if you admit a patient to the hospital for chest pain to rule out acute coronary syndrome, instead of using the ICD-10 code for chest pain, if applicable, such that you think the condition is unstable angina, then use the unstable angina ICD-10 code. This diagnosis is more specific and best describes your clinical impression. You should avoid ICD-10 codes that just state the mechanism of injury in trauma cases when a diagnosis can be listed. For example, if a patient fell from a tree, don't put that ICD-10 code first. List subdural hematoma or some other injury that was sustained from the fall. Frequently, doctors are confused about the term initial encounter versus subsequent encounter. Use initial encounter for the entire length of that illness. For example, if a patient was transferred to your ED from an outside hospital for a femoral neck fracture, you still select initial encounter even though you're the second ED to evaluate the patient. Subsequent encounters refer to follow-up visits after the initial encounter as an outpatient usually. Another important point, when documenting multiple final diagnoses, the order of your diagnosis is very important. As the first ICD-10 code, put the most important or most serious condition the patient was treated for. A patient may present with leg pain, but upon evaluation found to have bilateral lower extremity edema secondary to new onset decompensated systolic heart failure requiring admission for further evaluation and treatment. Although the chief complaint may have been leg pain, the ICD-10 code should be, quote, acute systolic congestive heart failure. This is a more serious diagnosis and should be listed as the first diagnosis, not leg pain. Why am I making such a big deal about the final ICD-10 code? As I mentioned in the second video on COPA, many insurers are now using the ICD-10 codes from the ED visit to determine the final E&M CPT code for the visit. They are not using the actual MDM grid which we have discussed over the first 4 lectures. Therefore, the ICD-10 codes are a major determination of reimbursement. Using the ICD-10 codes to determine E&M CPT codes is considered fraud and abuse and should not be allowed. But since insurers use it in some complex algorithms such as the United Healthcare Emergency Department Claim Analyzer, they somehow get away with it. ACEP has a policy on this, which states that the E&M CPT code choices should not be altered or discounted based on the patient's final diagnosis, a methodology that is never used to determine CPT code choice and which should not be used to either discount a physician's effort in arriving at an end-of-encounter diagnosis or to deny legitimate claims. So how does this affect billing? Well, using non-specific or incorrect ICD-10 codes will result in downcoding or denial of payments from the insurers. Downcoding is when a medical service or procedure is billed at a lower level than was actually provided. Payers often dispute the use of a high-level code such as an E&M Level 5 chart or 99285, and thus often downcode claims to a Level 4 chart or 99284. Many insurers want to identify ED visits that could be avoided, so a term has emerged, LANE or Low Acuity Non-Emergent ICD-10 codes. Here's the problem. A study from 2022 looked at multiple ICD-based algorithms to identify either preventable or low acuity visits to the ED. They found that 2% of the visits with, quote, low acuity ICD-10 codes ended up needing surgery, critical care, a cardiac cath, or even died. And the study concludes that, quote, these algorithms do not reliably predict low acuity outcomes thought to be associated with such visits, especially for adults 65 years and older. Further, The study states that these algorithms should be judiciously applied for research purposes and not used for clinical or payment purposes. Another interesting takeaway from that study is their list of top 20 ICD-10 diagnoses identified as low acuity across all algorithms, with the most interesting ICD-10 codes highlighted by me. Number 1, acute upper respiratory infection unspecified. That makes sense that this is probably a low acuity non-emergent diagnosis. However, going to number 2, urinary tract infection site not specified. This one may be low acuity, but also the person may be sick. I suggest using acute cystitis instead of urinary tract infection. Moving on to number 6, unspecified abdominal pain. If you pick the location or quadrant, hopefully you can move away from the term unspecified. Number 7, cellulitis of an unspecified part of the limb. Again, pick the limb or location. The biggest surprise is number 10, pneumonia unspecified organism. I don't know why this made the list, but I can tell you, if appropriate, try and use a different ICD-10 code such as bacterial pneumonia, not elsewhere classified. Also surprising is number 13 and 16. Number 13 is unspecified asthma with acute exacerbation. I would try and pick mild, moderate, or severe asthma and just use your best medical judgment as to which one it is. COPD with acute exacerbation, there's not really another ICD-10 code here, so I don't know how to describe this one. To summarize, if you use one of these 20 ICD-10 codes, the ED visit may be eligible for review and downcoding. Another reason complex patients are being downcoded is because the ICD-10 codes do not show the complexity of the encounter. Now, we should be showing the complexity by the MDM portion of our note, including COPA, data, and risk, but the insurers will use the algorithm to look at the ICD-10 codes. When applicable, use multiple ICD-10 codes and be specific. When appropriate, use terms like acute, severe, mention the body location, and try to avoid the terms unspecified or other in the ICD-10 codes. I recognize this isn't always possible. As another example, urosepsis has no ICD-10 code, so which ICD-10 code should you use? Urinary tract infection site not specified? Nope, this is a lane ICD-10 code. Start with the most serious diagnosis first and then list all other problems. So in this case, you'd start with sepsis unspecified organism, and if you're using EPIC, put the diamond on this diagnosis to show it's the principal diagnosis, then list urinary tract infection site not specified. Here are more examples. If someone is pregnant and it influenced your ED management, add the appropriate ICD-10 code for pregnancy. If someone has taken a DOAC and it changed your workup, then add the ICD-10 code for long-term use of anticoagulants. These ICD-10 codes show the insurers that the visit was more complex. One final point. Avoid using ICD-10 codes that start with history of, since insurers incorrectly assume that the problem has resolved. I recognize this contradicts common medical vocabulary, but here are some examples. If a patient's visit was influenced by their hypertension, don't use the ICD-10 code for history of hypertension. Use the ICD-10 code for essential primary hypertension. The same with lung cancer. Don't use history of lung cancer, just use lung cancer. On a side note, ICD-11 has been released, but it has not been incorporated yet. There's some suggestion it may occur in 2027, so you don't need to worry about it for a few years. Here's a summary for ICD-10 codes in the ED. First, list all ICD-10 codes for all diagnoses found and treated during an emergency department visit. When listing final ICD-10 codes, use the first diagnoses for the most important or most serious condition the patient was treated, and also use the diamond in EPIC to specify the primary reason for the visit. Use specific ICD-10 codes when appropriate, such as the terms acute, severe, list the body location, and try to avoid the terms unspecified or other. Avoid using an ICD-10 code that starts with history of, since insurers will incorrectly think this means the problem has resolved and it's no longer an issue. And finally, if there is no confident final diagnosis, then use the ICD-10 codes for the signs and symptoms. In the next and final video, I'll present examples of different cases where documentation made a large difference in billing and reimbursement. Please post any questions in the comments and I'll try my best to answer them.